Our final speaker for the conference is Dr. Andrew Kaunitz. Dr. Kaunitz is a tenured professor and associate chairman of obstetrics and gynecology at the University of Florida, where he also serves as the medical director at UF Southside Women's Specialist at Emerson. Since joining the UF College of Medicine in Jacksonville in 1984, Dr. Kaunitz has established a distinguished career in academic medicine, clinical leadership, and public health. He earned his undergraduate degree from Brown University and his medical degree from Vagelos College of Physicians and Surgeons at Columbia University, followed by an OBGyn residency at Northwestern Memorial Hospital. He also served as an epidemic intelligence officer in the Division of Reproductive Health at the CDC. Please welcome Dr. Andrew Kaunitz for his presentation, Treating Menopausal Symptoms and Evidence-Based Strategy.
First of all, I'd like to thank the leadership, including the past president and the current president of the Society, for the opportunity to be here. I see both of you in this room. I'd also like to point out that all the professional organizations I've worked with, none have been more supportive of, or better organized or better utilizing high tech than your society. And a particular shout out to Nicole. Yeah, they treat their speakers very well. So good, it's just a pleasure. And finally, a big thank you to everyone in this room who shows the dedication to their menopausal patients, such that you're here to the bitter end of this conference. So thank you so much for hanging in there. Okay, and with that, to start by giving a shout out to Dr. Joanne Pinkerton, a friend and colleague who's an OBGyn up with University of Virginia in Charlottesville, and her statement that well-informed clinicians can change the conversation, removing fear from discussions of hormone therapy, can help our patients make sound decisions regarding safety, risks, benefits of menopausal hormone therapy. Basically, her phrase really encapsulates what I hope to accomplish in the next 30 or 40 minutes. I do have some disclosures. And there's some abbreviations you can be aware of. What we used to call North American Menopause Society has a new name, now the Menopause Society, TMS. All right, so with current demographic trends, our patients often will be spending substantially more than 1/3 of their lifespan as menopausal women. With that in mind, I'll briefly review menopausal vasomotor symptoms. We'll talk about Women's Health Initiative data, specifically data looking at risks and benefits of oral conjugated equine estrogen with or without MPA. We'll look at outcomes including breast cancer, coronary heart disease, and venous thromboembolism, including pulmonary embolism. We'll talk about risk of breast cancer with estrogen-only therapy, including pointing out some very recent data that I have found surprising and somewhat counterintuitive, and you may find have the same reaction. We'll talk about risk of breast cancer, comparing risk with natural progesterone versus synthetic progestins. We'll talk about differences in safety of transdermal versus oral route of administration of estrogen with respect to the outcome venous thromboembolism. We'll also talk about practical issues in terms of initiating systemic hormone therapy to treat symptoms. We'll talk about a new non-hormonal treatment for symptoms. And finally, looking at a very recent article, we'll detail use of menopausal hormone therapy in high-risk BRCA mutation carriers with intact breasts who have undergone risk-reducing BSO. And I'm happy to know that there's at least one, if not multiple, GYN oncologists in the room who may find this topic of particular interest. Again, my hope is that we can change the conversation focusing on evidence and therefore helping remove fear from discussions that we may have with our menopausal patients regarding pros and cons of hormonal therapy. Well, we're all familiar with hot flashes. Our patients sometimes use different terms and insist they never have hot flashes, they only have hot flushes or night sweats. I think my favorite term must be from a particularly creative patient who refers to her menopausal symptoms as private summers. We know that these symptoms are associated with feeling sweaty, sometimes a feeling of palpitations or anxiety. Some of you may be old enough to remember that a few decades ago, Oprah was suddenly hospitalized and got a big cardiac workup for palpitations. And in fact, she was experiencing perimenopausal symptoms, fortunately not heart disease. Feelings of hotness or feeling sweaty that last for an hour or all day are very unlikely to be caused by menopause, because menopausal symptoms are fleeting. They come and go quickly. And what's particularly clear about vasomotor symptoms that they represent the most common reason our menopausal patients seek care at the time of the menopausal transition. Not all women experience vasomotor symptoms, but more than half do. And we know that symptoms are most severe and most frequent, not late in menopause. Not late in menopause, but in fact in late perimenopause and early menopause. This is when patients are most likely to be symptomatic and come to our office for care. Some fortunate women, their vasomotor symptoms only last months or perhaps a year or two, but unfortunately the mean duration of bothersome vasomotor symptoms is measured in many years, and in fact it's about 1 decade is the mean duration of bothersome symptoms. That is a sobering observation to discuss with symptomatic women, but it's important that they understand this duration issue in terms of making good decisions about treatment. Much more recently, we've been learning that bothersome vasomotor symptoms that are happening today seem to be associated later in life with both negative cardiovascular outcomes as well as cognitive outcomes. And there's some fascinating work being done by the neuroscientists, menopause-focused neuroscientist Pauline Mackey in University of Chicago, and also Rebecca Thurston in Pittsburgh, including looking at neuroimaging changes associated with symptoms versus age-matched women without symptoms. And some of it's been, unfortunately, somewhat disturbing in terms of vasomotor symptoms seeming to be a predictor of negative cognitive outcomes. Well, it's important to point out that not all women with symptoms merit treatment, but when symptoms are disrupting daytime activities, particularly when they're disrupting sleep, I point out that if a symptomatic woman is waking up several nights a week or every night feeling sweaty, having difficulty getting back to sleep, she's like an intern who's on call every night of the week. And that lack of restful, needed REM sleep can end up causing daytime mood issues as well as cognitive issues with impaired memory. So when vasomotor symptoms are impairing quality of life, we do need to strongly consider treatment. And in terms of the most effective treatment, there is no controversy whatsoever that estrogen is highly effective with at least a 75% reduction in symptoms in well-controlled placebo trials. It's not only frequency, but also severity of VMS that are reduced with both transdermal as well as oral estrogen. Okay, so it's very clear that vasomotor symptoms represent the most common reason that a menopausal woman presents to our office seeking treatment for menopausal issues. In addition, the efficacy of hormone therapy is very well established and not at all controversial. What is controversial is the safety of hormone therapy. And of course, that brings us to Women's Health Initiative. Some of the older folks in this audience have heard a description of WHI many times, but some of the younger members of the audience perhaps not so much. This was the largest women's health study ever funded by the NIH, and it recruited women, and I'll want to emphasize, it recruited women aged 50 to 79 years at baseline. I don't see 65 and 70-year-old women coming to my office for the first time for treatment of menopausal symptoms, but we did recruit in WHI women as old as 79 years at baseline. And the reason there was such a, that we recruited women of this age was that we needed the statistical power to look at hormone therapy's impact on cardiovascular diseases as well as cancer and other chronic outcomes. If we had only included younger women, there wouldn't have been statistical power, for instance, to assess, for instance, impact of hormone therapy on breast cancer. So the mean age at which women was screened was almost in mid-60s. It was 60 to 63 to 64 years. Although it was planned for this trial to continue for a decade, the larger part of the trial, with about 17,000 women with an intact uterus who were randomized to oral estrogen and MPA versus placebo, that was stopped after a mean follow-up of just over 5 years. The smaller part of the trial, with almost 11,000 women post-hysterectomy, continued considerably longer, almost with a follow-up of almost 7 years of women on study medication, hormone therapy or placebo. So let's talk about findings, starting with the larger EPT study that was, again, stopped by the Data Safety and Monitoring Board after a little more than 5 years of enrollment. We initially noticed that in the first several years, the Kaplan-Meier curves for hormone therapy in pink versus placebo in blue did not diverge, but after 3 to 5 years, you can see the risk of being diagnosed with invasive breast cancer became higher with E plus P versus placebo. Notice that the relative risk was less than 1.5, and also notice that the bottom confidence limit was 1.0, meaning that this association between use of estrogen progestin therapy and risk of breast cancer, it was only of marginal statistical significance. Coronary heart disease, including not only myocardial infarction, but episodes of angina. Again, a small elevated risk with hormone therapy compared with placebo. But in the 2002 initial findings from WHI that in the summer of 2002 created so much fear and havoc regarding hormone therapy. For those of you in the room old enough to remember, I had patients who literally flushed their hormone tablets down the toilet and then came back to me 6 weeks later that, well, my symptoms have returned, what do I do now? In that first 2002 publication in JAMA that resulted in so many headlines, not only in the US but around the world, it's sort of hard to understand, but there was no age-stratified analysis presented. But we'll spend some time talking about age-stratified analysis because that ends up being of great importance. Okay, and then the statistically biggest risk with hormone therapy was not neoplastic or arterial cardiovascular events, but in fact VTE, including an elevated risk of pulmonary embolism, more than a doubling in risk. This is similar to what we see with oral contraceptives, with oral estrogen. Again, keep in mind that WHI only studied oral estrogen. It did not study transdermal estrogen, and we'll talk about why that's important. Okay. Receiving less publicity was that EPT as well as ET was found to reduce the risk of osteoporotic fractures. Not a surprising finding, but demonstrated very clearly in the WHI data. So as the Data Safety and Monitoring Board looked at interim findings, seeing more risks than benefits, there was a decision to prematurely stop the study after just a little bit more than 5 years of women taking their study drugs, hormones versus placebo. In contrast with the EPT study, the smaller ET study of women post-hysterectomy showed a much more benign outcomes with ET. There was no significant impact on risk of coronary heart disease, venous thromboembolism, or colorectal cancer. In fact, there was a significant reduction in risk of breast cancer as well as osteoporotic fractures. So overall, ET seemed to be safer than EPT based on WHI findings. ET study was stopped early, but after about almost 7 years of follow-up. And the reason it was stopped is that there was a marginally elevated risk of stroke with ET compared with placebo. Overall, the ET findings, which were published several years after the 2002 report, also in JAMA, received quite a bit less publicity than the EPT findings. Okay. The bottom line is, since 2002, there a dramatic decline in prescriptions of hormone therapy has occurred in the U.S., and what we see is that many clinicians, including our colleagues, including OBGYNs, continue to be reluctant to treat women with bothersome symptoms. And I guess qualitatively, my sense is this is particularly true in younger colleagues. There's a very broad reluctance to consider systemic hormone therapy in symptomatic women. So the pendulum after WHI publications in 2002 and beyond, the pendulum swung away from a moderate evidence-based perspective really to a fear-based perspective. Because of this, and because we noted that our patients, that menopausal women with symptoms who in fact might be excellent candidates for hormonal management, because there's, because such women were having such difficulty encountering clinicians who were knowledgeable and comfortable about prescribing hormone therapy, Dr. Joanne Manson, who's a medical endocrinologist and a literally globally famous clinical trialist, she and I published a brief essay in the New England Journal just talking about how there's been an overreaction to findings of WHI to the point that good candidates for hormone therapy don't have access in the United States. And we talked about hopefully getting clinical care of menopausal women back on track. Dr. Manson's also the lead author of what I consider the most important WHI publications, looking at 13, 18, and 20-year follow-up, both with EPT and ET, and I'm going to spend a few minutes detailing the findings of her studies. First of all, with 13 years of follow-up, there continued to be a small but significant elevation in risk of breast cancer with EPT. In contrast, also with 13-year follow-up, women post-hysterectomy randomized to ET were noted to have a persistent, modest but significant reduction in risk of breast cancer, as you can see here. For instance, you can see the 21% risk reduction with invasive breast cancer in the ET group. So when you're talking with a menopausal patient who has an intact uterus and you're prescribing estrogen plus medroxyprogesterone acetate or Provera or northindrome acetate, synthetic progestins, one way to talk about this elevated risk is to point out that among 1,000 EPT users, the number of additional cases caused by EPT would be less than 1 per 1,000 users annually. That level of magnitude of elevated risk would be considered by World Health Organization to be rare. I find that when I'm talking with college-educated women and looking at this risk quantitatively, a lot of patients will say, well, is that what all of the hoopla, what all the fear is about? Because I can live with that level of elevation and risk. Whereas a lot of other women, particularly less educated women, or perhaps women who've been personally impacted by breast cancer occurring in a close friend or a loved one, any elevation in risk of breast cancer might be unacceptable, and they just don't want to even consider hormone therapy. And I think our job is to work with the patients where they are and respect their perspectives on risk and whether or not they want to use or not use hormone therapy. But if you're like me and you have a number of menopausal patients using hormone therapy in your practice, keep in mind that as women get into their 50s and 60s, the incidence of breast cancer keeps going up and up. It's sort of like prostate cancer in men. And that if any time you have a patient on hormone therapy diagnosed with breast cancer, she will understandably assume that it is the hormone therapy that we prescribed that caused her breast cancer. And yet we know very clearly from the WHI trial that among women on hormone therapy diagnosed with breast cancer, only 1 in 5 cases can be attributed to use of hormone therapy. And we know from the placebo group that 4 out of 5 such cases would have occurred with or without hormone therapy. That's not a discussion I have with my patients, but it's a discussion I'm happy to have with colleagues. I think the reality that breast cancer starts becoming so common in this age group, and there's such a sensitivity to the concerns about breast cancer in this population, I think that alone explains why there's very understandable reluctance to use hormone therapy. Now, with 20 years of follow-up, and now we're up to 2020, with EPT, there continued to be this small elevated risk of being diagnosed with breast cancer. Looking at mortality, this elevated risk did not achieve statistical significance, but it's congruent with the elevated risk of incident breast cancer. And when we turn to the smaller ET trial, women post-hysterectomy, we can see that the significantly lower incidence of breast cancer persists with 20-plus years follow-up. And importantly, a 40% risk reduction, a significant 40% risk reduction in mortality from breast cancer was noted in women who were randomized to conjugated equine estrogen versus placebo. Okay. That's a statistic that's very real. I think we can go to the bank with it, and yet I think very few physicians and almost none of our patients are aware of this information. Okay. So again, a significantly lower risk of breast cancer, incident breast cancer, and a significantly lower risk of death from breast cancer within the ET group. So are these findings a fluke and only apply to use of conjugated equine estrogen, which we use much less than we used 2 decades ago? Well, it turns out there's some very recent data addressing this issue. First, from Dr. Klobowski, who's an active medical oncologist with WHI based at UCLA, and then also Dr. Manson and her colleagues. They aggregated findings from 10 randomized trials, WHI being far and away the largest, but 9 other smaller trials. And these were trials not only of conjugated equine estrogen, but also estradiol. And when they looked at risk of breast cancer in these randomized, in these aggregated trials, among women randomized to estrogen alone, 3.6% of women in these trials were diagnosed with breast cancer versus 4.7% who had been randomized to placebo. So it's not just WHI, but in fact, the worldwide literature at the time of publication of this 2024 paper demonstrated that there was a significant lower risk of being diagnosed with breast cancer for women participating in any of these, in the aggregated 10 randomized trials. Their conclusion was that the totality of randomized clinical trial evidence supports a conclusion that estrogen alone use significantly reduces breast cancer incidence. Now, how does one react to this data? It's very counterintuitive. You know, we all know that tamoxifen, by blocking breast tissue estrogen receptors, and that aromatase inhibitors, by blocking endogenous production of estrogen, reduce recurrent breast cancer and reduce death from recurrent breast cancer. So how can it be, if these anti-estrogen agents are so effective in reducing death from breast cancer, how can it be that that use in women with no history of breast cancer, use of estrogen reduces risk of breast cancer? It's counterintuitive. I don't have an explanation for it. I think anyone who comes up with a valid explanation perhaps will get a round-trip ticket to Stockholm to pick up the Nobel Prize, because it is a major conundrum. But nonetheless, the data is very clear. And adding to the clarity of the data is an even more recent publication from this year in Lancet Oncology, looking at the use of hormone therapy in younger women, women less than age 55, and looking at the outcome, invasive plus DCIS, in women less than 55 years, aggregating data from 13 observational studies. The risk of being diagnosed with breast cancer with no hormone therapy, 4.1%, with EPT, slightly higher, 4.5%, similar to what we saw with WHI, and with estrogen alone, significantly lower risk, 25% lower risk of being diagnosed with in situ or invasive breast cancer. Furthermore, the earlier hormone therapy estrogen therapy was started, and the longer it was used was associated with more protection against being diagnosed with breast cancer. So this reduction in risk of breast cancer with estrogen is real. I wish I knew how to explain it. Okay. Now, as important as breast cancer is as an outcome when we're looking at hormone therapy in menopause, perhaps the most important outcome would be all-cause mortality. Dr. Manson looked at this with her 18-year follow-up article, and noted that whether women used EPT, the larger trial in women with a uterus, or ET, the smaller trial in women post-hysterectomy, all-cause mortality was similar with both clinical trials. Mortality from cardiovascular disease, as well as all types of cancer in aggregate, were also similar. But again, remember that WHI recruited not only what I would consider clinically relevant women in their 50s, the women who might come to us seeking treatment for symptoms, but it also recruited women in their 60s and all the way up to age 79. But Dr. Manson didn't make the mistake that was made earlier in the 2002 paper. She looked at age-stratified results. And lo and behold, when women of what I would consider the clinically relevant age, that is women within 10 years of the onset of menopause or women in their 50s, when you look at that group, hormone therapy was associated with a small reduction in overall mortality, and then incrementally higher risk of overall mortality when you looked at women initiating hormone therapy in their 60s and 70s. So these findings add credence to what is called the timing hypothesis, and which postulates that if hormone therapy is initiated early, it does not increase the risk of coronary heart disease, and in fact may reduce coronary heart disease morbidity and mortality, as well as overall mortality. However, if initiated later, hormone therapy does increase coronary heart disease risk. It's it's provocative that the timing hypothesis may also apply to type 2 diabetes and also dementia. Clearly applies to coronary heart disease, but it may apply to these two other important disease states. Okay. Well, I think we need, WHI we should put it sort of in the rearview mirror. It taught us a lot, but I think we can move beyond WHI in terms of type of progestational agent we use and route of estrogen delivery system. So there's no randomized trial data, but there's an important, fairly recently published study using British data with more than 40,000 cases of breast cancer based on the UK Family Practice Database. All with the National Health Service in the UK, all patients participating in National Health Service are kept track of in this national database. And with estrogen progestin, and the progestin in the UK was mostly MPA, just like WHI, notice that the relative risk was essentially identical to what was seen in WHI. So this is a real elevation in risk. It is modest or marginal, but it is, I believe it's real. In contrast, among women who were prescribed estrogen plus natural progesterone, there was no evidence whatsoever of an elevated risk of being diagnosed with breast cancer using hormone therapy versus non-use of hormone therapy. And then the findings of this large British analysis were paralleled with the findings from an earlier, smaller French cohort that, again, very similar findings. Okay. Let's look at route of estrogen administration. Remember, the biggest risk with hormone therapy, far and away, was the risk of VTE, including pulmonary embolism. Although, again, no randomized trial data, there are a number of observational data studies of varying quality. All of them show that VTE risk is increased with oral, but not with transdermal estrogen therapy. I think given that it's plausible, we know that transdermal estrogen doesn't increase the liver's production of clotting factors, for instance. Given the biologic plausibility and the consistency in the findings of these observational studies, I counsel, and I would recommend that you counsel patients, that patch or transdermal estrogen is safer with respect to VTE risk than oral estrogen. I still use oral estrogen in some of my patients, but only in those patients who have a normal BMI and therefore don't have an elevated baseline risk of VTE. For my patients with an elevated baseline risk of VTE because of their BMI, I strongly prefer use of transdermal, which in my practice would be patch, but there are other types of, there's lotions and gels and even sprays. So for obese patients in particular, I would strongly encourage use of transdermal versus oral estrogen therapy. All right, let's talk about some practical issues and then move on to a relatively new non-hormonal agent for symptoms. So in my practice, here's some sort of scripted examples of how I talk with women who are considering starting or perhaps coming in to consider a refill of hormone therapy. If there's no uterus, I'll point out that estrogen therapy does not increase and in fact reduces risk of breast cancer, which is going to be new information for essentially all of our patients. I'll also point out that while oral estrogen increases risk of blood clots, and I'll reference use of oral contraceptives because a lot of our patients have heard that before. In contrast with oral, transdermal estrogen does not increase risk of blood clot and therefore is safer, particularly in higher risk women, including high BMI women. When a uterus is present, estrogen with natural progesterone does not appear to impact risk of breast cancer. In contrast, if we're talking about estrogen with a synthetic progestin, I'll point out that after 3 or more years of use, estrogen EPT slightly elevates the risk of being diagnosed with breast cancer, underscoring the importance of continuing and consistent mammograms. Why would I, in my practice, since I do believe progesterone is safer from a breast perspective. Why do I have some patients who are using synthetic progestins? It's because synthetic progestins are more potent in suppressing the endometrium. So if your patient has fibroids and she's sort of at high risk for bleeding, or she's experienced bleeding during use of hormone therapy, and she had her imaging and she had her benign endometrial biopsy, but you don't want her to have future episodes of bleeding, you might switch from progesterone to synthetic progestin. And the most potent synthetic progestin that is widely used in menopause in terms of suppressing the endometrium would be norethindrome acetate. And norethindrome acetate is available in transdermal combination formulations as well as oral combination formulations. And if there's questions about this, I'd be happy to address it after the talk. So there's still a role for synthetic progestins, but in terms of starting women on hormone therapy, I tend to start using transdermal estradiol and micronized progesterone, and I encourage women to take the progesterone only at bedtime because it does make women sleepy, which can be a good thing. If I'm initiating hormone therapy, I'm going to start with a standard dose of oral estradiol, which would be 1 milligrams, or I rarely prescribe CE because it's still branded and more expensive than oral estradiol. But the standard dose would be 0.625, which was used in WHI. And if I'm starting on a patch, I'll prescribe 0.0375, or more commonly in my practice, 0.05 milligram patch. Now, I note that understanding the dose of patch or transdermal estrogen, if for OBGYNs that don't often prescribe hormone therapy, this can cause some confusion and concern about what's the right dose. I think it's fairly easy to keep track of the right doses with oral, but it's important to keep in mind that while a 1 milligram estradiol tablet means that each tablet has 1 milligram of estradiol in each tablet, very straightforward, a 0.05 patch means that patch releases 0.05 milligrams of estradiol daily. It can be a little confusing for those providers who don't prescribe hormone therapy often or transdermal often to keep track of what's the appropriate dose. And again, in my practice, and I would recommend in yours as well, that if you have high-risk women such as obese women, start them not on oral but on transdermal estrogen. Once symptoms have resolved for several years on the initial dose of estrogen, as with the first bullet, I would try to go to a lower dose of estrogen. A lot of women will be reluctant to do that, but I'll say, well, if your symptoms return, just send me a patient portal message and we'll put you right back on the higher dose that you felt well on. But this also brings out one of the other advantages of transdermal estrogen, that, for instance, patches come in 5 or 6 different doses. And so they're much more adjustable than oral estrogen, which come in a more limited number of doses. And I use all of the doses in my practice, but I start with the standard doses listed at the top of this slide. Okay, let's talk about a newer non-hormonal treatment. Until we learn more about hypothalamic, until we learn more about hypothalamic pathophysiology, the antidepressants, including paroxetine, venlafaxine, were my go-to non-hormonal treatments for vasomotor symptoms, and particularly in breast cancer patients where we don't use systemic hormone therapy. Paroxetine, venlafaxine have probably about like a 50% or so, 55% efficacy in treating hot flashes. This new agent, fezolinetant, has a higher efficacy than that. You can see 64% in pivotal clinical trials versus 45% placebo response in these trials. However, in the clinical trials, uncommon transaminitis or elevations in liver function tests were noted. About, wait, has a mind of its own. Sorry. Okay, so because elevations in LFTs were more common in the active medication group versus placebo, the FDA in its initial package labeling said, check baseline LFTs and don't start if they're elevated, and if they're not elevated, you can start, but then repeat LFTs every 3 months, so basically at baseline 3, 6, and 9 months. Because later on, after fezolinetant was released, the FDA became aware of a case of a woman not only with asymptomatic transaminitis, but also some symptoms of liver toxicity. The package labeling is now stricter and says that basically if women start fezolinetant, check baseline 1, 2, 3, 6, and 9 month LFTs. So it's become sort of a bigger deal, and we're asking more of ourselves and our office staffs as well as our patients in terms of LFT monitoring with this medication. Something also to keep in mind, as with all newer medications, it's expensive, and often pre-authorization is required prior to use. I have noticed that some of my patients do very well with the cards that you can download online and your patients can print out. Okay. The last issue I'd like to discuss comes from this month's Green Journal. So I'm focusing on high-risk women with BRCA mutations who have intact breasts but have undergone, this is why I've never been a fan of animation with PowerPoint. It's very common that among women with BRCA mutations, many of whom have lost one or multiple relatives from breast cancer, it's common that they may be reluctant to undergo risk-reducing gynecologic surgery, BSO, because they know that then they're going to be having bothersome symptoms, and they don't want to have to take estrogen to treat these bothersome symptoms because they're scared that this will elevate their risk of breast cancer if they have intact breasts. Along with my colleagues, Chanda Reese, who's a minimally invasive GYN surgeon in my department of Jacksonville, and with my colleague, Joanne Pinkerton in Virginia, we were asked by the editors of the Green Journal to look at this issue. And we identified 6 observational papers, no randomized trials, but six observational papers looking at mutation carriers with intact breasts who had undergone risk-reducing BSO prior to age 45. And what we found was that aggregating the findings of all of these papers, hormone therapy, number 1, does not elevate risk of breast cancer in this high-risk patient population, and I'm sorry about the slides. And the abstract as well as the results section point out that given the emerging data on the potential of estrogen therapy to reduce breast cancer risk, clinicians caring for women with BRCA mutations should consider offering not only BSO, but also hysterectomy concomitantly at the time of BSO as part of risk-reducing surgery. And that is a different, that's an evolution in standard of care in the treatment of women with these high-risk mutations. I might add that the editors of the Green Journal were very enthusiastic, really close to insistent that this language be included both in the paper but also in the abstract. And this language also mirrors that from the group of Stephen Narode, N-A-R-O-D, in Canada, who's probably the foremost investigator in the area of hereditary breast and ovarian cancer. That he's also a big advocate for hysterectomy being performed at the time of BSO because of what appears to be important risk reduction in terms of risk of breast cancer in those BRCA patients with intact breasts. All right, so I hope I've made the case that by staying up to date and aware of current evidence, we can, as we discuss hormone therapy and treatment of symptoms with our patients, we can discuss this without fear and help our patients make sound, evidence-based choices in terms of treating their symptoms. I'd like to, again, thank the Society for the opportunity to give this talk.
Thank you to Dr. Kaunitz for this presentation, for distilling it down to very evidence-based, practical recommendations, and for practice-changing work, at least from my perspective with what I do daily. So thank you for that. Questions, Dr. Newton?
Yes. Hi, thank you for giving this talk. My name is Bradley Newton. I'm a generalist in Savannah. I use a similar approach to what you were describing. I prescribe transdermal estrogen with micronized progesterone. I was wondering if you could talk about the dosing, whether you prescribe, daily or nightly micronized progesterone, or like the 2 weeks on, 2 weeks off, which I've also seen described.
Okay. Yeah, it's a great question, and I hope there'll be a lot of practical questions like that. So, and I'm not trying to be glib or facetious, but